go through fluids. I know you've all had fluids taught to you hundreds of times now, every year probably, every firm that you do surgery or anaesthetics. So I'm just going to try and do it slightly different. We've got some props, which either are going to work or going to make a mess, and we'll just see how it goes. So obviously fluids, we need to talk about maintenance and resuscitation. We're going to talk about prescribing fluids, common errors that we see, the dreaded calculations that I know you had the exam last week, but they will still come up in finals and you actually have to do them in front of an examiner, which is sometimes a bit... So I've got a few easier ways, I think, of doing it, and then working out drip rates. So the first case, a 54-year-old person, it doesn't matter, presents with severe diarrhoea and vomiting. That's all you get. What would you do? Assess the patient. Good start. So how would you assess the patient? So A, B, C, D, E. Okay. So to say they're stable, they just walk into the GP. Would you just suddenly go, A, patent, B, breathing? Another way you could assess? History. Okay, good. So history. And I think that is important. In finals, obviously, if you say A, B, C, D, E, you get marks. But be sensible. If they're someone who's just sitting there in a history station, you don't need to do A, B, C, D, E. So we go history, examination, investigation. So in the history, what would you, and then obviously the management. So in the history, what would you want to know, thinking about someone who's diarrhea and vomiting in a fluids lecture? So how much diarrhea, how much vomiting? How long for? Someone said here, can they keep any fluids down? That's really important when it comes on to your management. Anything else? They've been for a wee recently. Excellent. Anything else? You have a 10-minute station for history. So, sorry? What's their intake been like? Recent travel. Good. Was it? Blood's in this way or that way. Anything else? Anyone else sick? Anyone else sick? Anyone else had it? In stereo. Excellent. So this gentleman has had vomiting for 3 days, 2 days of diarrhoea, unable to tolerate any oral fluids for 24 hours. Is that good, medium, bad? No fluids for 24 hours? Really bad, yeah? So that's why it's important, because people will come to you with all variety of diarrhoea and vomiting and all variety of any condition. And these sort of small things make it important. No food for 24 hours. Ate a dodgy kebab, probably the cause. No recent travel. Feeling unwell, which is important. Thirsty, so you need to ask about thirst. They're feeling lightheaded with standing, which might give you an idea. Weeing less, no feverish symptoms, and no past medical history. So I think these things in the history are the most important things. Make sure you ask them. Okay, so now you've taken your history. That is the history. How would you examine the patient? So JVP, cap refill, blood pressure, pulse. Good. So you all kind of have the idea, but again, try and get a structure in your head. I know there's a few of you jumping out, but I do split this into A, B, C, D, E, because I think with the fluid status, there's components of each of the letters that are important. So A usually isn't. So when respiratory rate and how they're breathing, so this gentleman here, accessory muscles of respiration, if that's caused by his dehydration, that's a really bad sign. Cool peripheries you talked about, which would come onto cap refill, and dry mucous membranes. Okay, and now we're going to try and use some little things. So, just. How do I do that?
Just north of your bit of A4, there should be a button where the light is.
That was good, north. I'd have gone for superior, but north's fine. Oh god, I need to give him the whole game away. Okay, So here are the obs. Okay. So so clever, this, isn't it? Okay, cool. So what do we think of those obs? Can you see them? Let's zoom in a bit. Is that all right? Okay, let's zoom in a bit more. The bottom one says Muse of 6. That doesn't matter. He's alert. So these are the obs we need. Okay. So anyone want to comment on these obs? Good. So everything. And some good things? Apar. So respiratory rate is 24, so a bit elevated. So generally, you're looking at the blood pressure and the pulse. And have you heard of a seagull sign? Anyone talk to you about that? Where the heart rate is above the systolic blood pressure. So 110 is above 95. It's a really bad sign if someone's unwell. If they're not unwell, then it's an irrelevant sign. But if they're generally unwell, which this man is, and they've got heart rate above systolic blood pressure, that's bad and should prompt treatment, thoughts, something to do. Now I need to come back onto these. Can you see these? Can you read these up here? No, okay. Thanks. This is technology at its best. Okay. So then moving on to the assessment. So again, you can structure your assessment in any way. Investigations, we talk about bedside investigation, blood tests and imaging. And I think that's, again, a reasonable structure. So the patient's weight. Why is the patient's weight important? So a marker of fluid loss. So if you've never met the person before, there's no real use of it, but what other use could it have? As a baseline? Yeah, good. So use it to calculate things moving forward. So use it to calculate the fluid you need to put in. Use it to calculate their urine output. It's really important. And then moving forward, like Tim said, and we said here, that a baseline, and that we can then, if this man, we look at him and we decide he's dehydrated or hypovolemic, we'd expect his weight to go up with time. Maybe not from 100, you'd want to be losing weight, but it's a marker of their fluid status if we're saying that they're, and again in the other way, if they're fluid overloaded, you can see their weight coming down. It's a good marker of how fluid overloaded they are. And then urine, looking at the ketones and the bloods, obviously using these and the full blood count. Looking for either signs of infection or you can have hemodilution giving a high hemoglobin. Okay, so then management. So IV access. So this is my tool. What size cannula would you put in this guy here? Gray. A big one, a grey. Anyone else? Green? Anyone kinder? Pink? Someone orange here? Yeah, it's good. So I think for this guy, I think pink or green, maybe grey, but you don't really know. I think it depends how they are, but bigger is better. So this is this is a litre of fluid here. This is attached to an orange cannula, which for you who don't know, it's the biggest one. And this one's attached to a blue one here. How fast do you reckon we'll empty these? And the other game is that Andy doesn't think that these buckets hold a litre. So we'll see. We've got some Haribo, so a bit of honesty and quickly. Write down how many minutes, seconds, hours you think it's going to take. Let's go with the orange one. Write it down, because then you can show your neighbour and you're not lying. So how long do you reckon a whole litre will go through an orange cannula? And guess the blue as well. And then I'm going to open them up and we'll carry on. Okay, everyone written them down? Okay, we'll give Paul a head start. We're going. We're off. Okay. Okay, we'll carry on because it'll take... I know, I thought there was a kink in my orange one. It's going to ruin the whole effect. So let's go on to a fluid challenge now. So how do you do a fluid challenge? You give some fluids. Wicked. So how much fluids? 500? Or 250? When would you give 250? Yeah. Guys, that's awesome. When you're F1s, please give 500. The amount of people who you say fluid challenge, they give 50, and then they wait a bit more. Confidence. So if they're fit and well, no comorbidities, you basically are not worried about them fluid overloading, you give 500. If you're worried, you give 250. So, and then what do you do? So you recheck the obs, particularly the blood pressure and the heart rate. And when do you recheck it? So you need it sometime. So 15 minutes later is a general idea. So we've given our first fluid challenge. What do we think of that? It's creeping up. So that's good. So what do we do? Give how much more? Same again. Wicked. So this has worked. So you think then that it's hypovolemia causing these obs. Yeah? You get that bit? So then we give more to correct it further. And, a bit better. And say even the obs times are in here. 20, 30, 20, 45, 21. So keep checking every 15 minutes. And when do you stop? When do you just keep giving it? So we've given a litre now. So what would we do here? Okay, give more. Cool. So yeah, you can give up to 2 litres. But I can't remember which I said. I've just spread things out a bit here. So then you get to 2 litres or you're 1.5 litres and you're happy. So you'd be happy with these obs now, wouldn't you? Yeah. So you don't need to keep going with a fluid challenge up to 2 litres. As long as you've got your diagnosis and you know it's fluid that's caused these symptoms and these obs, then you can say, okay, I've got him back to a good level now, heart rate of 85, blood pressure of 115, 75, everything else looks fine, we're happy. So then what do we do? Oral. Poor chap hasn't kept anything down for 24 hours. Send him home. Get him home. No, so you give maintenance fluid. So how quickly would you give maintenance fluid to this guy? Well, we said 100 kilos. 6, 8? Yeah, I think be more... So 4, I reckon 2 maybe. If he's a fit, well, 100 kilo guy. Just think when you're dehydrated, you go home and you drink a pint of water, and that's 500 mils, and you just, some of you can just finish it in one. Some of you can do it in much quicker than 15 minutes. Finish it in one, and then if you're about 20 minutes later, you're still dehydrated, you'd happily do another one, and then you could easily drink 2 litres of water over the next 2 hours, or a litre of water over the next 2 hours would be nothing. Go to the Union, they drink 5 litres. Okay, look, we're nearly there. Ooh, okay, so I think we might overflow. But yeah, okay, so you get it. So this is a successful fluid challenge. So you've challenged them with fluid, and it's worked. So you know that that's the cause of that. So now, seamlessly coming back to this. So I'm not going to dwell on this because everyone's decided that crystalloids are now the thing and colloids are the thing of the past. But you will have all gone through this before. Just a few little comments. So now, just to clarify, we use crystalloids for basically anything, for resus, for maintenance, and for in emergencies. We use crystalloids. because there's big research to show, she's leaving, there's big research to show that crystalloids do the same in these situations as colloids. This has only happened in the last couple of years. The big things that you need to remember, that if you're worried about someone, the only time really people use colloids now is if you're worried you're going to fluid overload them and you want something that will stay in the intravascular space for a bit longer, then you could give less colloids than crystalloids to get the same effect. But other than that, very rare situation, you use crystalloids. A few things to point out. So just you don't need to remember all of these numbers, but Hartmann's is great. You'll just prescribe it, or Plasmolite, as they have started using at Imperial. Has lactate in it, so if you've got someone with lactic acidosis, don't give them Hartmann's. It's a general rule. Hartmann's you can also not add something to, so you can't add more potassium to Hartmann's. So if you've got someone who you're worried about potassium, you need to use one of the saline or glucose and add something to it. Colloids you can have a anaphylactic reaction, which is obviously not good. And I think, stop, so orange is empty. So that was really quick, wasn't it? So who said less than 10 minutes? Oh, bloody hell. Okay, so we need some honesty here. The time exactly was 5 minutes and 12 seconds. 5 minutes, 12 seconds. 5:15. He did it to seconds. What do you? Anyone better than 5:15? 5:12. Wicked. 5:12. Quickly. That's so quick, isn't it? And Miss Little Blue is still petering along. So it's really important. I think that maybe shows how quickly you can get fluid through if you put the right size cannula in. If you use a Little Blue or an orange in these situations, you'll come stuck. Yeah, so I'm annoyed that they changed all of the crystalloid-colloid argument, because I made this really good diagram about what the difference is, so just humour me. It does still ring true. But so crystalloids go all the way through, the colloids, you see what I did, so it's pretty good. So I keep showing it even though it's not really that relevant. But yeah, so crystalloids used for everything. And the reason I don't dwell too much more on it is that they're not going to ask you in finals which type of fluids to give, because it's a disagreement in medical fields. There won't be anything that's got a disagreement in. So they won't ask you. It's more for... Okay, so this is our fluid challenge. So we're all happy, 250 to 500, and then reassess. Okay, so quickly then, what can happen in the other situation is... So this lady now comes in. So you can see, so she's had an emergency caesarean. I use some obstetric cases, one because I'm an obstetrician, but also because it's really simple and you can make points quite easily. So this person had a caesarean section's lost a lot of blood and is septic. So surprisingly has now presented with exactly the same obs as our last gentleman. So we've all agreed. But then you give your fluid challenge, and what do you think of this? Same, yeah, pretty much, a bit worse.
Worse.
Yeah. They all of you agree it's worse. And worse. Ooh. Then we stop. That's when the nurses start doing 4-hourly obs. So you can see the same starting picture. You do your fluid challenge, you challenge her with fluids, and it hasn't worked. And so you need to think what else is causing his or her now situation and it's not fluid. So at this point, you don't then just go and put more fluid up because you've challenged her and it hasn't worked. And so you now need to think of what else. And in this scenario here, sepsis is a reasonable other cause of her observations here. Okay. So how would you prescribe that? Just in view of time, I'm just going to show you rather than... So if you're really, really good, you'll prescribe your fluid challenge as well as your fluid. Most people won't. Most people will just start on this, on the top line and just write 1 litre. But if you're being a good student or if you're in an exam, this is how you should prescribe your fluid challenge. So Hartmann's is what we've given. You've added nothing. And the top line, you've done your 250 mil or 500 mil IV stat, and then you've signed it and put your bleep number. Okay. Let's see if this is... Any questions about anything so far? No? Cool. So we'll just come on to fluid balance now. So fluid balance, so we'll go back to our first gentleman, and he's been now on the ward for another 24 hours. The nurses, as per your guidance, have put him on a fluid balance chart, so an input-output chart. Are you all happy with input-output charts? Yeah? Okay, we'll see. So after a day, our chap... So very reasonable, common exam question would be, so this is over 24 hours, what is the fluid balance for this patient? So quickly do that. So there's nothing for the first 6 hours, so I'll just come down here. Anyone? Okay, so it's not... Anyone? So we've got 200 in the positive, 300 in the positive, 300. Are we all happy? Anyone not happy? Want me to go through it more?
Yeah, how do you work it out?
How do you work it out? Thank you. Someone just say it. If you're not sure, just ask. So, annoyingly, I can't use my cursor on here, but this side of the blue line, is the input. So at the top, I didn't show you very well, but this is the oral input. This is the IV input. And so what should have been done is the middle line here should have had each hourly input added up. So then at the end of your 24 hours, in this box, you write your total input, and then the same on output. So I think this was vomit, this was something else, and this was urine. So you add up, again, all of your output, and so then input is positive, output is minus, and you get the balance. Okay? Our blue bag's still running here. So yes, so it's not that difficult. So now we've got our gentleman who, if you remember, had lots of diarrhea, lots of vomiting, and we'd given a fluid challenge, we were happy. So what strikes you about this fluid chart? It's really confusing. Yeah. Have you ever seen a fluid balance chart written like this? No, never. And this is how they're meant to be filled out. And it took me quite a long time to do it because you mess one number up. But it's not confusing. This is how it's meant to be filled out. So just in case you weren't sure. So this side of the arrow, this side of the line, is the hourly input. And then this is the running total input. And then the same on this side. So a positive balance of 1 litre over 24 hours for our guy who was severely dehydrated. Would you be happy with that? Yeah. Yeah? You'd probably want a bit more, considering right at the beginning we gave him 2 litres, and only then were we happy with his observation. So then to leave him 22 hours being essentially negative 1 litre. But positive is at least a start. And then what happened So this is another example. It could come up. What happened here? So the catheter's still in. So yeah, excellent. So the catheter's blocked. So you see here, the urine output's gone from being reasonably good to 0. If it starts to tail off, so if you have someone who's getting sick and losing their urine output, it will usually tail off, or it will be 5 or 10 or something. You very rarely, if they've got a catheter in, you very rarely get an output of 0. So their catheter's blocked here. Okay, so I'm aware of time. So we're going to just finish the... No? Okay, we'll finish. Had to say so. Okay, so all happy with prescribing. I've got a few fluid prescription charts here, but not enough for all of you. But make sure in the next few weeks you just pick one up from the ward, take it home, and just make sure you're happy writing prescriptions and writing fluid. So prescriptions probably won't come up in finals much, but the fluid prescribing will. So they'll have this station, and you'll have to attach a fluids bag to a cannula and do these sort of things. So make sure you're happy with that. So in terms of prescribing maintenance fluid, again, it's often really easy because if they're eating and they're well, then maintenance fluid is just, you can just top them up with maintenance fluid. If they're eating and drinking, then Hartmann's is very reasonable. And that will be most of your prescriptions you'll do on the ward as an F1. But the problem is that most nurses will come to you with that fluid chart the same time as the one that needs urgent review or has got abnormal U's and E's. So you just, until you get really comfortable, you have to go through the story with taking a history, maybe not a full examination, but at least looking at the observations of the patient, and then particularly looking at the electrolytes before you prescribe maintenance fluid. Obviously, if they're nil by mouth, it's much more important, your input. So let's just do the calculation. So just anyone shout out the answer to that. So what is the drip rate required for a unit of blood, which is 400 mils, we'll call it, over 4 hours using a giving set with a drop factor of 20 mils. 20 drops per mil. So we've got 30 and 33. Yeah, okay, cool. I think 30 is fine. Are we all happy? Probably not. Okay, so I've got loads of ways you can do it on this presentation, but I'm just going to go through quickly here, real time. So in these things, I prefer to split it into two things. So the volume and the time. So look at them as separate things. So volume, just try and visualize what they're actually asking. So you've got a volume which is 400 mils. So they've told you that in the question, yeah? So then you think, how many drops is in 400 mils? And I think this is much easier. Think of the total amount of drops. And they've told you in every, there's 20 drops in 1 mil. Okay, they told you that. They told you that in the question. So how many drops in 400 mils? 400 times 20, yeah? So 8,000 drops. It's a hell of a lot of drops. Okay, and then time, they said 4 hours. But the question was asking drops per minute. So 4 hours times 60, so you get 240 minutes. And then you get your calculator out. You will have a calculator, 240, which equals, trust me, it's 33. So you're going to... So we're happy with that? It's quite simple. And I think the thing that people find difficult with these calculations, they try and do the whole thing at once. Just split it into volume and time, and then work out those bits, which is very easy, and then combine them together. So 33 drops per minute. So try and set that up on one of these little things is impossible. So it's reasonable then to round it to 30 drops, so 1 drop every 2 seconds. Yeah? So you get this drip rate, which is going super fast now, and you want 1 drop to come out every 2 seconds, and you move this little dial to make that happen. And they will make you do that in OSCEs. I think I had that. Do that calculation, and then put up the fluid, so you need to put the giving set in, etc., and then set the drip rate. That will come up, well, it did in my year anyway. And then, so I've put other ways. There's an equation if you would prefer to use it. This is the way I prefer, just to think about the whole thing. And then you can look at the units if you're a geek. Okay, and lastly, just before we finish now, can we set up, can we do this one? So what's the transfusion rate, mils per hour? Blood transfusion, 40 drops per minute. And giving set is 20 drops per mil. Anyone? 120. You were about to say 2 something. Well done. Okay, so similarly, and lastly, again, I think that one's more difficult, but the question's up here to remind you. But again, the way I think about it is, if you look in 1 minute, so make it really simple, just think about it. In 1 minute, what would you do? So you've been told you've got how many drops? So you've got 40 drops in 1 minute. They've told you that. 40 drops in 1 minute. Then you need to find out how many mils this is. So this is 40 drops. They've told you that 20 drops in 1 mil. So you go 40 divided by 20. So that's 2 mils. Okay? So that's in 1 minute, you're going to drop through 2 mils. So then, but they've asked for it in an hour. So that's 60 minutes. So you times. So in 1 minute, you're having 2 mils. So in 1 hour, you're having 120 mils. Okay? Really not, there's a few blank faces, but are you happy with that? Reasonably simple. Yeah? So we'll stop there. What I've just put on, and which will all be obviously on the website, so there's those 2 that are blank at the beginning and then work through them, so you can do them at home. And then there's an equation if you prefer just to learn that and not think. There's the way to look through it, or there's the geeky way. And then there's 2 more with similar questions. And again, they can ask you to do that with the answers if you click through. Okay, so we'll stop there. So hopefully, our blue bag still hasn't finished. To tell you the official numbers are 4 minutes it should take an orange cannula to get through, and it should take over half an hour to get a blue cannula through. So it's really important. Any questions before we move on? No, perfect. So.